So thank you for that intro. Yes, I'll be talking about sleep in neurodevelopmental disabilities. And just to start, kind of a quick outline, I wanted to review some of the common sleep problems in pediatrics. And then we will kind of focus our discussion on 5 neurodevelopmental disabilities. So we'll start with CP and then move into Down syndrome, Prader-Willi syndrome, autism, and then ADHD. And I just wanted to acknowledge that while we'll get to a lot of common neurodevelopmental disabilities, there's actually quite a few more that do have really interesting findings in sleep. So just kind of keep that in mind as you may see patients with different neurodevelopmental disabilities. It's really important to kind of recognize that sleep might be playing a role in some of these, even if we don't discuss it today. All right. So when we think about sleep problems in children, what do we mean? I generally think about 6 categories, with the first and very common being behavioral insomnia of childhood. And so when we think about that, it's often limit setting, problems with parental limit setting, or it could be more of like a sleep onset association. And then obstructive sleep apnea is a big one in children. In toddlers and preschoolers, really the driving issue is the adenotonsillar hypertrophy. And then as we get into older age, and especially more recently, obesity has become a big factor in obstructive sleep apnea in children. And then we have disorders of hypersomnia, like idiopathic hypersomnia or narcolepsy. And then parasomnia is one of the very common ones, being night terrors. And as kids get a little bit older, they can have sleepwalking. And then there are sleep-related epilepsies, particularly the frontal lobe epilepsies that can be very challenging to figure out. And then lastly, we have sleep-related movement disorders. So these would be things like restless leg syndrome or a more newly described disorder called restless sleep disorder. Okay, and so with those problems in mind, I think it's important to really think about how these might affect kids with neurodevelopmental disabilities. They are highly prevalent, more so than in typically developing children. And then the other kind of issue is that they are often lifelong. So whereas a typically developing child might kind of grow out of their sleep onset association insomnia quite quickly, a child with a neurodevelopmental disability may not kind of grow out of that, and it might kind of continue to be a problem for years. And then also, research has shown that in typically developing children, poor sleep can lead to kind of cognitive functioning issues, language acquisition. It can worsen externalizing behaviors during the daytime. And so all of those things are things that kind of children with NDD already suffer from. So kind of recognizing that sleep might be worsening these problems for them is important. And then I think it's good to recognize that these problems are going to impact the entire family. Often our patients might have intellectual disability and might kind of rely on family as their primary caregiver. And so if they are not sleeping, then the caregiver is not sleeping either. All right, so to start, we're going to talk about cerebral palsy. And just to review, this is really a broad disorder, but fundamentally, this is a non-progressive disorder of movement. And it's secondary to some injuries sustained either in utero or early infancy. And you can kind of classify these by either the body type that's involved or by kind of the primary movement problem, whether that's spasticity, kinetic movements, or ataxic movements, or some combination thereof. And commonly, these children have comorbidities like epilepsy, cognitive dysfunction, and then sleep problems. So as you can imagine, sleep problems in CP can be kind of run the gamut and be a wide range of presentations and severities as well. This graph here, I liked it. It shows you kind of 106 patients were in the study that had cerebral palsy, and they graphed them by their gross motor function classification scale. And you can see that the more impacted their motor function was, those children were more likely to have positive pediatric sleep questionnaire screens, meaning that they had some kind of sleep problem in a couple different domains that were kind of looked at with the questionnaire. And whereas the children that just maybe had scored a 1 for their gross motor functioning, so were more mildly impacted, may not have had as many sleep problems. This study actually also looked at children with kind of the comorbid presentation of cerebral palsy and epilepsy, and found that together was more likely for those children to also have obstructive sleep apnea versus having either CP or epilepsy, either one of those. And then thinking about kids with epilepsy, and cerebral palsy, which is relatively common, about 30% of children with CP will also have epilepsy. And then they are, again, more likely to have sleep issues. So why might that be? Well, I think that's probably a couple of different reasons. Oftentimes, children that have CP and epilepsy have severe kind of Lennox-Gastaut type of epilepsy with multiple different seizure types, including tonic seizures, which can cluster at nighttime and be really disruptive to sleep. And then 2, they sometimes need multiple medications or medications that are kind of sedating during the daytime. So that can lead to issues with sleep as well. And then I think important for these kids is thinking about their spasticity issues and the pain associated with that. And especially as they are more impaired in terms of their motor functioning and their spasticity is worse, if it's not effectively treated, that can really lead to nocturnal pain and trouble sleeping secondary to that. They have done some studies looking at kind of more aggressive management for spasticity with Botox injections, and also with continuous intrathecal baclofen pumps, and showed that those patients and their families were reporting better sleep through the night, less nocturnal arousals, and doing better in that regard too. And then children with CP can have kind of various different sleep-related breathing issues. So if we think about kind of what their systemic issues are, they oftentimes have trouble managing secretions. They are more at risk for aspiration. And so they already kind of have this compromise to their lungs and their upper airways over time that they're sustaining. And then you add in things like their neuromuscular weakness. And so kind of central sleep apnea, obstructive sleep apnea, and nocturnal hypoventilation can all be found in these children. And they might not be kind of the typical loud snorers and things like that we might see in more typically developing children. All right. And then I thought it was interesting to recognize kind of parental attitudes towards sleep in children with cerebral palsy. So this article kind of took the parental perspective about what their concerns were around their kids' sleep. And so they kind of categorized it into things that they were concerned about in the home, as well as things that they were concerned about in the healthcare setting. And you can see in the home, they were worried about possible sleep disturbances, how to monitor their child at nighttime. And then in the healthcare setting, they really felt like there was limited attention for sleep. There's kind of this overload where they have a lot of problems going on, and it's hard to kind of get to every single one. And then they were also concerned in terms of kind of the first line treatments and the medication that their child was getting, kind of melatonin, which didn't seem, personalized kind of to them and what solutions might their children be going through. And so I think this is kind of a nice way to highlight what we can do a little bit differently in terms of the healthcare environment, trying to be more proactive about asking about sleep questions, and then really kind of directing our treatment towards what we're hearing from them. And that might be more behavioral interventions for the family to do at home, and that kind of thing. All right, so we'll shift focuses right now and we'll move to Down syndrome. So as we know, Down syndrome is the most common genetic disorder. It is a trisomy and it's caused by inheritance of an extra chromosome 21 or a part of an extra chromosome 21. And then kids with Down syndrome have a characteristic facies. They typically have short stature, they can have intellectual disability, hypotonia, hypothyroidism, and then can have congenital heart disease as well. So that all plays a role in their presentation with their sleep problems. And so I think the most unique aspect of sleep in kids with Down syndrome is their sleep disordered breathing and how high a rate of sleep disordered breathing that they do have. It's actually so common that the AAP has recommended any child with Down syndrome should have a sleep study by 4 years of age. And there's really multiple factors that contribute to this increased risk. So that includes obesity, their kind of propensity to develop reflux, which irritates and inflames the upper airway, low muscle tone from hypotonia, and then hypothyroidism as well contributes by increasing soft tissue deposition in the upper airway. And then they have differences in the craniofacial structure of their face and upper airway as well. And I really like this slide on the right side because it really goes through kind of all the differences for kids with Down syndrome and where kind of obstructions or problems are going to be. And so you can see mid-face and mandibular hypoplasia here. They might have more prominent lingual tonsillar hypertrophy instead of kind of your more typical adenoid and tonsillar hypertrophy. And so there's a lot of differences and things that contribute to sleep disordered breathing in these kids. All right. And so in terms of specific diagnoses, so we see central sleep apnea more commonly in really young kids and infants with Down syndrome. And that can be treated with supplemental oxygen. And then obstructive sleep apnea, as I mentioned before, is highly prevalent. So 30 to 50% of kids with Down syndrome will have obstructive sleep apnea versus like 1% about in the general pediatric population. And that risk only increases as kids with Down syndrome become adults. And they've done studies showing that adults that have untreated sleep apnea are at even higher risk of Alzheimer's dementia, which is something, you know, that they're already at risk from having Down syndrome. And then two, they can have nocturnal hypoventilation. So this kind of continued kind of lower oxygenation levels. And it's important to monitor with carbon dioxide in these children that have Down syndrome because you could miss that diagnosis of nocturnal hypoventilation by just kind of screening for sleep apnea. All right. So treatment for sleep apnea is the same as in typically developing children. So we would start out with an adenotonsillectomy as first-line treatment. And this has been studied in kids with Down syndrome. And while it is very helpful, unfortunately, it's not as effective as typically developing individuals. So there's a higher incidence of persistent sleep apnea. About 40 to 70% of these children can have persistent sleep apnea. So it's important to think about what kind of follow-up and sleep study they might need even after surgery. And I think what interests me as a sleep doctor is the kind of the subset of population with sleep apnea and Down syndrome, but that actually get worse after we take their tonsils and adenoids out. And I have two studies here highlighting kind of looking at that. So it seems to be about 15 to 18% of children with sleep apnea will actually have worsening of their sleep apnea after the first-line recommended surgery of adenotonsillectomy. And this 2017 study found that there was a relation between worsening of sleep apnea and hypothyroidism that was already present in the patients. And then this more recent study was a little bit bigger. They found a risk with increasing age. And you can see here that its predictive probability that they'll still have sleep apnea was increasing with age, which makes sense because, you know, adenotonsillectomy is not first line as you get into adulthood because there's other problems going on. But also asthma, children that had asthma were at increased risk. So I think that's just good to kind of warn families. And, you know, we've seen a shift kind of with how ENT thinks about these kids, and as older children and children with kind of comorbidities, they may kind of evaluate a little bit differently, consider doing a drug-induced sleep endoscopy prior to initial surgery to kind of try to evaluate where the obstruction in that airway may be. All right, so we'll shift gears again and talk about Prader-Willi syndrome. And so this is, sorry, let me just make sure. Okay, sorry. So Prader-Willi syndrome is a paternal loss of chromosome 15q 11 to 13 deletion, and that could be from deletion, imprinting, or uniparental disomy. These children present with severe hypotonia in infancy, and they often have eating problems and failure to thrive early in life. And then that kind of transitions to this excessive eating, obesity, hypothalamic dysfunction, and intellectual disability as they get older. And the one important thing to recognize for PWS patients is that there is treatment with growth hormone. And this has been shown to improve motor and cognitive development, as well as height attainment in these children, and improve body composition. And if it's given early, that these children are more likely to attain a normal IQ range. So it's really important to get started early. But there is one contraindication to starting, and that would be in the setting of severe untreated sleep apnea. And the reason being is that growth hormone can increase your lymphoid tissue. And if it's kind of started with a patient that already has severe sleep apnea, this could kind of lead to an acute airway obstruction. And so it's suggested that a sleep study be undertaken prior to initiation of growth hormone, and then again monitoring kind of a few months in. And so I think, either that or that's sometimes not attainable. So at least screening for sleep disorder breathing symptoms needs to be done before starting growth hormone. All right, and so for kids with Prader-Willi syndrome, the most common sleep-related problems are either snoring or having excessive daytime sleepiness. Sleep disordered breathing rates in these kids run about 80%, so it's very common. And similar to Down syndrome, central sleep apnea is kind of most common during infancy. And then we have kids more commonly presenting with obstructive sleep apnea or nocturnal hypoventilation. And you can see kind of the risk factors are kind of shared with what Down syndrome kids have, with one additional thing being that kids with Prader-Willi have an abnormal ventilatory control. So they have this blunted response to hypoxemia. And then that can really lead to the nocturnal hypoventilation issue. All right. No, I'm sorry. Excuse me. So thinking about treatment for sleep apnea in Prader-Willi syndrome. So similar to Down syndrome, the first line treatment is adenotonsillectomy. And so that is typically pursued when there is evidence of tonsillar hypertrophy. And then again, similar to Down syndrome, there is that increased risk for refractory sleep apnea. And so it's recommended to do a post-op sleep study to ensure that they are either fully treated or to identify that residual sleep apnea and treat them with PAP or something else. And then just to remember, while they are on growth hormone, there can be kind of that development of sleep apnea because it does increase the lymphoid tissue. So thinking about screening them for snoring or sleep problems intermittently while they're receiving treatment is important. All right, so to switch gears to the other issue for children with hypersomnia, and that would be, for children with Prader-Willi syndrome, is the issue of hypersomnia. So these children are likely having daytime sleepiness kind of from multifactorial issues. So often there's untreated or undertreated sleep disordered breathing. They also often have poor sleep quality in and of itself. And then they can also have hypothalamic dysfunction. And the presentation ends up being very similar to someone that had like primary narcolepsy. And we actually often refer to this as narcolepsy-like features or a secondary narcolepsy. And the reason we don't kind of consider them to have primary narcolepsy is because it seems that the etiology or kind of pathophys, it seems to be a little bit different. So people that have narcolepsy, they often enter REM sleep immediately, which we see in children with Prader-Willi, and they can have cataplexy, or this sudden loss of muscle tone with retained consciousness. And children with Prader-Willi can have cataplexy too. However, kind of where this starts to differ is that patients that have primary narcolepsy are almost always kind of positive for this HLA DQB1 0602 subtype. And then you can see that it's not as common to find in children with Prader-Willi syndrome. This was a study that looked at 60 kids with PWS, and out of 12 of them, only one had the HLA subtype, and actually one of them with normal sleep had it as well. So it's not more common when having secondary narcolepsy. And then also in primary narcolepsy, one of the hallmark findings is very, very low CSF hypocretin or orexin. And then when we study kids in PWS and obtain CSF, we don't find that low hypocretin or orexin. All right. And then thinking about kids with autism spectrum disorder. So this is a very common and kind of diverse spectrum disorder. They have deficits in social communication, as well as in restricted and repetitive behaviors. And then that comes out with behavioral concerns and commonly sleep problems as well. The most common sleep problem in kids with autism is insomnia, and it seems to persist into adulthood. So this was a study done at Vanderbilt in 2017. I looked at about 30 patients that were adolescent or adult age, and they found that compared to kind of typically developing age and sex matched peers, that they had a longer time for sleep latency, so taking almost 40 minutes to fall asleep, and that their sleep efficiency was worse, 79% versus 85%. And then these kind of issues with sleep really have a lot of daytime consequences for children with autism that might already have some behavioral issues. And this is some of my research that I did last year, looking at kids, over 200 patients with autism. And the blue lines are kids that have insomnia, but also other sleep problems. And what we found was it's very common for those children to have snoring and restless sleep. And so this just gives a hint that we might be missing some of the other issues that children with autism have. And so, you know, sometimes it's really challenging to get them evaluated for obstructive sleep apnea because of ability to kind of tolerate the sleep study. But screening for these things is important so that we can kind of work with families and figure out how to best treat them. All right, and then lastly, I'm going to talk a little bit about ADHD and sleep issues. And so, you know, of course, this is a very common diagnosis with core features being inattention, distractibility, and then impairments in executive functioning that should be seen in at least 2 places. And what we see in terms of their sleep problems is that children have a very high rate of insomnia. And they've actually shown in some studies that children can have a delayed dim light melatonin onset, suggesting that these kids might actually have a little bit of a delayed sleep-wake phase, which might be contributing to the insomnia that we see. And they've also shown that there's an association between ADHD and restless leg syndrome. And then finally, you know, there's always a question of, as ADHD is treated, especially with stimulant medication, is this also impacting their sleep? And at least one study I looked at, it does seem to be an issue. So they put children on either Strattera, atomoxetine, so a non-stimulant, and compared that to kids on methylphenidate. And in the 2 groups, they found that the children on methylphenidate had kind of a longer sleep latency than the kids on atomoxetine. So, you know, there's a fine balance there, and it may be worthwhile if sleep is starting to become a problem, thinking about switching to a different agent. And then think too, it's good to think about as a diagnosis of ADHD is being made, that sleep problems, is particularly obstructive sleep apnea, can present with kind of hyperactivity and challenging daytime behaviors. And so screening again for sleep problems as we make that diagnosis of ADHD can be helpful. All right, so thinking about treatments, these kind of hold true for autism and ADHD. So this table is from an Australian study, and they did a randomized control trial seeing if some behavioral interventions for insomnia could help kids with autism and ADHD. And so they found that in their primary outcome that they did have improvement of inattention during the day. And they also found that the kids that received these behavioral interventions, which are listed here, had improved quality of life. They had fewer days late to school, and they had increased sleep duration. So they showed nice kind of improvements in a lot of different fields. And I think the hardest thing is to actually get families to implement this. So of course, in this controlled study, they had a sleep psychologist working with them and calling the families and educating them about sleep hygiene and sleep behavioral interventions. And so there was a lot of focus on sleep. But I think if you have motivated families that are able to kind of implement some of these changes at home, that is really the first line thing to try. And then there have been studies looking at melatonin specifically in the population of autism and ADHD. That's shown that it is effective and helpful. And then clonidine too can be helpful, especially when thinking about kind of balancing stimulant medications and adding clonidine kind of in conjunction with those. It can be helpful in kids with ADHD to improve their sleep. All right. So kind of in conclusion, I hope that this was a helpful review of some of the kind of common neurodevelopmental disabilities and disorders that we see, and kind of what questions in the sleep history might be helpful to kind of tease out an issue. And as you do that, I think, at least I see in my clinic, that there's some kind of benefit to children's behavior or cognitive functioning, or just overall physical health. All right, and then I just have some references on these pages. Happy to answer questions.
Thank you so much, Dr. Singer. That was a great talk. And I really think sleep is such an important component of a healthy life, especially for epilepsy patient. I always make sure I ask about their sleep quality and everything. It can be really a game changer. So I am not seeing any question. 1 second, there is one question just popped up. Can you give us your sleep hygiene script talk?
Yeah, I would say, so you'll think about, I usually ask them what their bedtime routine is, and then what kind of activity their kid gets during the day, and then tailor it to kind of the answers I'm getting. I found that if I give families the full spiel, 5 different sleep hygiene things, no TV, that they need to be in their bed and, with only books, that kind of thing. Sometimes that's not as effective. And so I really try to get a history of what their evening looks like with their family. And then I'll give 1 or 2 pieces of advice. But I'm happy to share kind of a sleep hygiene list and so that you can think of kind of what you might want to try.
Yeah, I need some of those advice for my daughter also, I guess.
Yeah.
Thank you so much.